Hey everybody, and welcome back to another edition of the Physiotutors podcast. As you can see, we're live today in the studio, and we've got with us Jo Nijs. Welcome. So if you're unfamiliar, Jo Nijs is the grandfather of Central Sensitization, so to speak. So it's an honor and a privilege to have you here with us and talking to us live in the studio. He is a researcher, educator, and one of the founding people behind the idea of what central sensitization is, what its effect is, and where we as physiotherapists can then start to use it. It's enough from me. It's not me you've come here for. Jo, take it away. If you can maybe take 2 or 3 minutes to introduce yourself, what it is that you do, and then we'll go from there and we'll just dive on into the conversation.
Okay,
Welcome.
thank you. Thanks for the introduction. I would say that Clifford Wolff is the founder of the idea and the one who invented the mechanism of central sensitization. I think we try to contribute to it in a more clinical way and explore how the mechanism can be assessed and treated in the clinic. I think that's something we with the Pain in Motion group worked on for years now. And that brings me to what you asked me to do, to introduce myself, which is working at the University of Brussels and also at the University of Gothenburg, where I'm a professor, and I lead the Pain in Motion group who does work in the area of physiotherapy and conservative interventions in general for people with chronic non-cancer and cancer-related pain.
Okay, fantastic. So, as you mentioned, you guys do a lot of work within the realm of central sensitization. Maybe you can take a few minutes and, without going too deep into the weeds, explain to us what it is, what's going on, and what its relevance is to us in clinic.
Well, it relates to an increased sensitivity of the nervous system, as if the alarm system in your body is switched on. And it's a rather physiological response of the human body when to somehow protect the human body and to regain homeostasis. For instance, if somebody is confronted with a traumatic incident, for instance, a car accident or a surgical intervention, then it makes perfectly sense that the central nervous system switches on its burglar alarm, if you want to call it that way. So the alarm system is switched off, making sure that the human body will not do too much and will allow the possibly damaged tissues to heal, and that the human body in general to recover from the traumatic event. On the other hand, that physiological upgrade in activity in the system cannot be kept for a long time. And what we see in many patients with chronic pain is that this alarm system is not turned off again afterwards, and that in the chronic phase it kept on being activating. And of course, as the increased sensitivity of the central nervous system is adaptive in an acute subacute phase, but in a chronic phase it becomes really maladaptive, and therefore it becomes somehow a pathological state. And therefore it's really relevant for clinicians to recognize this, because it also starts to dominate the clinical picture of the patients. And in many patients, of course, presenting to you in the clinic, you then get a series of observations from specific examinations, from imaging findings, from blood results, test results, and you see many different things which are abnormal, and then you consider, okay, this is probably why this patient is in pain or also is having fatigue and other symptoms. But this somehow is mimicked by the increased sensitivity of the central nervous system, which is mainly responsible for the majority of those symptoms, and therefore it's really relevant to recognize this, to make the right judgment, and also to not direct the treatment to those things that are currently not really responsible for the symptoms that the patient is presenting.
Okay, there's a lot to take in there. Now, if we go back to what you mentioned there with the analogy that you gave of the body's alarm system. So it's triggered by something, be it an accident, be it a fall down the stairs, or some kind of insult to the body. Do we have any idea as to why the body then doesn't return to its normal homeostatic position? Do we know why that this then flips over into the chronic state? Have we any ideas as to why that's occurring?
We don't have a full picture about it, that's for sure. There has been a number of studies looking into that, and we have learned from those studies. And for all that we know, of course, it depends from patient to patient. Obviously, there are large inter-individual differences, but in general, we know a few reasons why the system is not turning back to its normal situation. One of those reasons is probably related to genetics in terms of, let's say, approximately 20%. Of course, those estimates are really difficult to make, but roughly people estimate this as 20% of it can be located in the genes. This implies that probably some people are born with some vulnerability to develop chronic pain once they are confronted with an acute traumatic or pain or injury or whatever. On the other hand, that's only 20%, implying that the environment is taking on the leading role in developing central sensitization in a maladaptive way in a chronic stage. And this also brings us to the field of epigenetics, the way that the genes are influenced by environmental factors. This brings us also to lifestyle factors. And this also brings us to how we cope with acute, subacute pain situations and the behavior of the patient, the coping strategy. And of course, those things we can influence. We cannot influence the genes, although, of course, environmental factors can also influence gene expression. Of course, so that's why the field of epigenetics is also that interesting, because of course it potentially allows us to somehow influence gene expression by changing the environment in a way that is adaptive, hopefully. So yeah, from those studies we've learned that we can hopefully also in the future prevent chronicity by addressing those factors sooner in the process than we are currently doing.
Okay. Great. I imagine going into the epigenetics could be a whole another podcast all of its own. Yeah. Absolutely. I want to ask you about what's the sort of time frame that we can look to for when this flips over from an acute episode to a chronic episode, for what we need to be aware of. But before we do that, could you perhaps give us, as best possible, I know this is probably quite difficult, some kind of idea of what's going on physiologically in the body? I know trying to simplify that into maybe a couple minutes worth of an answer is quite difficult. Yeah. But yeah, as best possible, trying to put it into some kind of nutshell as to what's going on in the body, why someone goes through this.
Yeah. Well, I will briefly answer the first part of your question in terms of the time frame. Then I would say a week, 10 days maximum is the time frame after a traumatic event for the nervous system to at least start switching back to the normal situation. And that's applicable in the clinic in terms of 10 days post-surgery. And then you can start to monitor it, of course. If after 2 weeks after surgery things are still very bad, then this doesn't look good in terms of prognostic situation for the upcoming weeks or so. So then it's probably best to start addressing it. Same is true for a car accident. that you in Whiplash research they have looked at it, and again 7 days to 10 days after the initial car accident, that's a good point to look at it. And normally then the majority of the patients have returned to, I wouldn't say the normal state of sensitivity of the central nervous system, but at least the sensitivity of the nervous system is returning back to its normal situation. So that's in terms of the time frame. I think it's a good indication. Of course, many patients with pain problems haven't had that day one, like in a surgical intervention or in a car accident. And in those patients, it's a bit more tricky, and then you cannot apply this 10-day guideline, which of course is a rough guideline, but still it provides some idea. But in those patients, I would be in any subacute stage, I would be careful to look at potential signs and symptoms of increased sensitivity of the central nervous system. I wouldn't do that in the acute stage, because of course then it makes sense for the body to have this kinds of increased sensitivity. But as soon as you are in the subacute stage, be aware of it. Not only be aware of increased sensitivity of the central nervous system, but especially be aware of those maladaptive beliefs, cognitions like catastrophizing, fear avoidance, and those kind of things, which are really important in relation to keeping the system high, keeping the system really active. So that's important in terms of applying this to the clinic. Second part of your question relates to really looking into what's happening in the human body when the alarm system keeps on being activated. Well, for all that we understand it right now, it relates to some extent at least to low-grade neuroinflammation. This implies that there is a low-grade neuroinflammatory response in the central nervous system. This implies that it is located anatomically in the spinal cord, but also in the brain. And this low-grade inflammatory situation keeps on driving the increased awareness, if you wish, of the nervous system in general. So not only for sensory input that potentially relates to the initial injury or tissue damage, but also to other types of sensory input like bright light, like odors, like a sound or whatever. And also you see that there is, because of that increased sensitivity of the central nervous system, typically the pain starts to spread beyond the area of where originally the injury or pathology is located.
Yeah, that area of insult.
Yeah.
Initially, yeah. You mentioned there sometimes it can be difficult with patients who don't have a day one. So this is also a phenomenon that can occur with people who've had no real traumatic insult, no traumatic incident, right?
Yeah, and that's of course a large group of patients, and in those patients we know that several factors lead to the increased sensitivity of the central nervous system, including sleep problems. We know that even perfectly healthy people, when they are exposed to a couple of nights, even 1 or 2 nights of sleep disruption, like sleep disruption experiments where they keep on waking up people at night, then you instantaneously the next day you see an increased sensitivity of the central nervous system. This is also then confirmed in observational studies where they saw that people having sleep problems start to develop increased sensitivity of the central nervous system. This is also now confirmed in a series of studies where they have looked at patients with pain, chronic pain, where they saw that sleep problems sustain the process of central sensitization. So that's one aspect, and that's also a key lifestyle factor that we need to address in patients with chronic pain to return the nervous system to a lower state of sensitivity. Luckily, 1 out of 2 patients with chronic pain has no sleep problems, but those who do typically have more sensitivity of the central nervous system, and we need to really address the sleep problems. We can with a conservative approach, so that's good news. But another key factor in relation to that is another key lifestyle factor, which is stress. Of course, stress and sleep problems are also closely connected, but we know also that stress is also probably even an etiological, but for sure in a sustaining factor for central sensitization. And therefore, also many of the patients who developed central sensitization without a day one, if you can call it that way, probably have stress as one of the main drivers of the process from the early beginning. And this relates to long-term stress exposure, such as having various major stressors in life. This can be whatever kind of long-term stress exposure, such as long-term conflicts in the family situation or at work, or also long-term stress due to financial problems, or in many patients also past traumatic events, sometimes even from the childhood experience, that haven't been dealt with properly, or that are still lingering, if you can call it that way.
Okay. With that said, then those lifestyle factors, they can account for at least a part of why the problem persists, right? And that goes for people who are both with and without a day one moment, so to speak. What are the most prevalent lifestyle factors, would you say then? Things like nutrition going to factor into that, or is something else going to be able to play into those lifestyle factors aside from what you've already mentioned with sleep and stress?
Yeah, I think in terms of the most prevalent ones, in terms of what we currently know, because not all lifestyle factors have been studied that much in detail in relation to chronic pain, but stress, sleep and physical inactivity are for sure the best studied ones, and we know that they are highly prevalent. Probably stress and physical inactivity is more prevalent than sleep, although sleep, like I said, is also very prevalent. Then also a bit less prevalent, but still also an important lifestyle factor for some patients with chronic pain is smoking. And we know that this also negatively affects the prognosis of patients with chronic pain for several reasons probably. But of course, this is a minority of the patients. Obviously, the majority of the population doesn't smoke, and this accounts also for the chronic pain population. You mentioned nutrition, and that's also probably an important lifestyle factor. We don't know everything about it yet, because this is probably one of the lifestyle factors that needs to be studied much more in detail. We're also working on that one. Anneleen Malvliet in our group is leading the research together with Tom Deliens and Peter Clarice from our university, who are the nutritional experts. And this is really an exciting area to look into. But for all that we know right now, and that the studies have been summarized in meta-analysis and systematic reviews, is that nutrition is indeed also a lifestyle factor that at least sustains the process of chronic pain, and also can potentially be influenced in a positive way if people take on a more healthy diet. Then there are nice results shown in the scientific literature from randomized clinical trials showing that this obviously has an added value on top of other evidence-based treatments such as exercise therapy, physical activity programs. So yeah, this is an exciting area. Again, this will not apply to all patients with chronic pain, and therefore it will always be a personalized approach to first look into the regular diet of the patient, and then you can explore whether there are possible benefits from a dietary intervention.
Okay. Yeah, what you said there right at the end with a personalized approach, N is always one. It doesn't matter what it is, whether it's central sensitization or whether it's a general musculoskeletal complaint. You have to address things for the person that's in front of you. It can never be a one size fits all kind of approach, as we're never going to get anywhere with any one. With that said, then, you mentioned there with sleep quite a little while back that it is something that we can have an effect on. What is our role in helping on the sleep side of things?
Well, it's a good one. Thank you for bringing that up, because that's something where in clinical practice there's a lot of room for improvement. The first major thing probably is changing the beliefs of the patients, because there is a general public belief that sleep problems can be addressed with sleep drugs, but this is for sure not the case. There is a substantial amount of evidence out there, not only in the field of chronic pain, but also outside the field of chronic pain, that sleep problems should not be addressed with drugs. Probably this public belief also sustains the sleep problem in many people, because they have such a strong belief that the sleep drugs are allowing them to sleep at least a couple of hours per night. But that this is obviously not the case, and on the contrary, the best evidence treatment for sleep problems is sleep management, the sleep management approach, which is nicely described and applied in the cognitive behavioral therapy for insomnia approach. And what we have contributed to that in the last couple of years is that we allowed physiotherapists to be trained by clinical psychologists who are experts in providing cognitive behavioral therapy for insomnia, and they then added cognitive behavioral therapy for insomnia to exercise therapy and educational interventions for people with chronic pain. And the results aren't final yet of a large trial that we did with that specific treatment, but intermediate results are very positive, showing that physiotherapists are actually able to provide and integrate the cognitive behavioral therapy for insomnia in best evidence care for people with chronic spinal pain. So those are really hopeful results. We just really received a large grant from the Flemish Research Foundation to also study this in people with osteoarthritis who have sleep problems. So we're very happy for that one to also because that allows us to also explore this in people with osteoarthritis. Also in the field of osteoarthritis, there are nice early studies showing that adding sleep treatment also provides an added value, but there is no definite answer to that question, so we're happy to explore that one in the upcoming years. But yeah, I'm not saying that physiotherapists are the primary profession to target the sleep problem, but at least it shows that clinical psychologists, physiotherapists, and probably also occupational therapists, nurses, whoever is keen within the healthcare system to learn about how to manage the sleep problem in chronic pain patients is probably able to do so, because it's not such a really complex or very difficult treatment, but of course you need to be open-minded to learn the approach, and if you're able to learn it, then of course it's important to integrate it into your care for your patients.
Yeah, to be able to apply it properly. And I think good sleep hygiene is something that's so undervalued. I think now, in the age of technology, everyone carries their phone to bed, their laptop with them, and a TV, and you've got all these multiple different screens that adds to the problem of being able to sleep. So these good sleep hygiene measures that I suppose would be applied within the CBT approach are to eliminate these external factors that are going to keep your mind awake. And have you any tips that someone could take away? Obviously, as you say, the study's still ongoing, but is there anything like reading a book before bed instead of watching your favorite Netflix drama kind of thing? Anything like that the listeners could take away today in order to make some use out of that and start some kind of approach on that?
Yeah. the sleep hygiene is important, as you mentioned it, but we shouldn't overestimate the importance of sleep hygiene. Sleep hygiene is like one component of the cognitive behavioral therapy for insomnia approach. It's one out of 4 or 5 components. It's often something we do in the first phase of the sleep management approach, if you can call it that way. And in that respect, you mentioned reading a book before going to bed. And reading a book is a tricky one. You also mentioned watching the television in your bed. That's a good one because that's something for sure you need to get out of the bedroom. In general, sleep hygiene addresses doing only 2 things in the bedroom, sleeping, and the other one you need to ask to the Physiotutors CEO, because he appears to be very well aware of all that. But I have clear restrictions from my university to not to address this in this interview.
Okay.
So, but in general. So sleep hygiene is focused on that one, and so keep as much activities out of the bedroom that do not relate to sleeping, and this implies also not to read a book normally in the bedroom. So then if we discuss this, for instance, I'm also treating patients, chronic pain patients in the University Hospital of Brussels, and I see that many patients have this routine of reading a book when they are in the bed, and it's actually part of their routine of being able to fall asleep. Then, of course, it's not a black or white thing. So we don't then say, no, you should take the book out of the bedroom, because strictly taken, that's what sleep hygiene advice says us to do. But of course, if it's part of their sleep routine of falling asleep, and I don't really have a problem of falling to sleep, but they have a problem of frequent awakenings, long awakenings at night, then keep the book as part of their sleep routine of going into bed. Of course, it's better if they read the book in a room outside their bedroom. That's even better, and explore this with your patient. But if it's not working well for the patient, then it somehow disrupts their sleep routine, then keep it as it is. Because the sleep routine prior to going to bed is very important. That's also part of the sleep hygiene program, that you explore with your patients what would be a good sleep routine for that patient, because you need to prepare your brain for decreasing the activity level in your brain, allowing the brain to switch on the sleep modus, of course. So that's part of it. Getting back to the not to overestimate effects of sleep hygiene. That has been studied well, and we know that providing sleep education to change their sleep beliefs and also the sleep hygiene, those two together, that has a positive effect on sleep. But in general, the effect sizes of that part of the sleep management program are not that large. And in that, if you have a really severe sleep problem in your chronic pain patients, you will not reinstall their proper sleep with only sleep hygiene and sleep education. Then you need something else, and then you need the most effective ingredient of sleep management, which is sleep restriction therapy. And it's not the most fun part of the sleep management approach, but it allows associative learning. It allows associative learning because you restrict the amount spent in the bedroom to a minimum in the early phase, and then this is the way to do associative learning and to allow the brain to link being in the bedroom to sleeping. Because, for instance, if patients only sleep for like 5 hours per night, then you restrict the time, but they spend like 8 hours or more in the bedroom, but they lie awake or whatever, then you restrict the amount that they spend in the bedroom per night to like 6 hours. And then, of course, they continue to sleep for like 5 of those 6 hours. And this allows for associative learning, for the brain to link being in the bedroom to not lying awake, but sleeping. And from there, you can gradually build up towards hopefully more sleeping hours, and also more time spent in the bedroom.
Okay. That's interesting. I don't know if you'll be able to provide any information on this one, but is there any link between social status and chronic pain, as what you mentioned there with the sleep and sleep restriction? If you're in a low-income situation where you potentially might have a studio or a one-bedroom kind of place, there's not a lot of room to diversify your activity, so to speak. So is there a link in chronic pain patients and financial social status at all?
Yeah, absolutely. And I'm glad you mentioned that, because it's often not addressed in either scientific literature or podcast or whatever. So yeah, that's a really important one to address, because there is more and more research to actually show that, and there is so chronic pain is affecting more people in a socially vulnerable situation, if you can call it that way. And also, when it affects those people, they are affected by it much more severely as compared to people who are having a much better situation, socially speaking, that is. So this is a very important issue. And I see this also in Brussels, of course. In the University Hospital of Brussels, we see a diversity of patients, and also with a diverse cultural background. And this is a real challenge for us as clinicians, because many of the established treatments for chronic pain, of course, are considered to be evidence-based treatments. But when you look at the social cultural background of the participants of those trials, I'm not sure they fully represent the diversity of people that we see in the clinic. So probably also in randomized clinical trial, there is an underrepresentation of the socially vulnerable people in our society. And therefore, we need to invest a lot of time and energy in adapting the current best evidence treatment programs to that specific group of patients, because they need us for sure. But unfortunately, we don't have a clear answer for that yet. But we know that it's a big issue, and we need to invest a lot in that group.
Okay. This is going more into anecdotal then. Do you notice a big difference in clinic about how effective the treatment is? Yeah, I do, and it's good that you emphasize that it's anecdotal, because we don't have evidence to support it. But me as a clinician, I don't get through many of the patients with a very different cultural background, for instance. And of course, the language can be an issue in that respect. Also, in a city like Brussels, where you have people from all over the world. Obviously, Brussels is, I think, the second most multicultural city in Europe, so that illustrates the diversity of patients that we see in the clinic out there. And this is, for instance, for pain neuroscience education, which is often the first ingredient of the multimodal approach that we provide. This is an issue, even though there are resources available like retrainpain.org, which provides nice pain neuroscience education online modules in multiple languages, more than 15 languages, I think. So you can get support from those kind of websites. But even then, it's really difficult to align with those patients. And the best tip I can give for that is do a thorough intake in terms of thoroughly questioning the beliefs, the perceptions about pain and about the cultural situation in relation to pain, because that clearly affects how they feel, think, and behave in relation to pain. But whether that is enough to allow us clinicians to adapt it accordingly and to hit the right spot, to also engage those patients into the behavioral approach that we are keen to apply on them, is still an open question. And I have to confess that I struggle in doing that in many patients with a diverse cultural background. Okay, interesting. Going to piggyback off of what you've just mentioned there at the end with doing a thorough intake, and bring it back a little bit more physiotherapy related. When someone comes into your clinic, what is it that you do then? What shapes your intake, whether it's questionnaires, whether it's talking about their beliefs, if you're using certain behavioral methods to address that? How are you going to conduct an intake? What's your approach?
Well, for starters, I do the general intake as every physio has been trained to do. So always also do the clinical examination. Because, of course, when you have an intake with a chronic pain patients, it becomes also a bit tempting to say, okay, this patient has seen several colleagues of mine before and several physicians before and brings in those reports. I don't need to do another clinical examination because this will increase probably the pain in my patient, and we know the results will be rather vague or non-specific or whatever, and it will not learn me anything. But I would recommend to always do also the classical clinical examination, because firstly it often learns you a lot about how the patient behaves and responds to it. Sometimes even you can find something which hasn't been addressed before. But even more importantly, it's important to build the alliance with your patient. If you just do history taking and questionnaires, I think that some patients will say, okay, I'm not being taken seriously enough. Also for the next phase, even if it is a clear non-specific type of chronic pain and there are no specific things that came out of the clinical examination, you can relate to this in the next phases of the treatment, especially during the explained pain phase, where you can relate for instance, if this is a case of central sensitization, you can relate the increased sensitivity of the central nervous system to the rather non-specific findings that you had during the clinical examination. For instance, if it's a low back pain patient, you can say, okay, remember that I was touching your lower limb for doing, for instance, a straight leg raise testing or whatever, and that you experienced that you said, okay, that hurts just touching the lymph. Well, that's a clear sign of central sensitization, probably. So therefore, you can relate those findings from the clinical examination that you did with the patient to your explanation. And that, of course, creates a bond with your patient, and the story becomes much more convincing to the patient. So that's, I think, a key message. In general, then, of course, do a thorough history intaking. Make sure that you allow enough space for the patient to tell their story. And from there, we then ask specific questions, and we also let them fill out a series of questionnaires. Of course, I only see chronic pain patients in the clinic, so for us it's easy that to ask them to fill out a standard set of questionnaires, not too many, like 4 or 5 that we use in a standard way before coming into the clinic for the first time. Of course, this is more difficult in settings where therapists see a variety of patients, obviously. But I would always ask them to fill out a number of questionnaires. And if you see a variety of patients and you don't know what type of diagnosis they have when they first come in, just ask to fill it out after the first intake, because that's also an option. If you only have like half an hour for an intake, I would spread the intake over two sessions if that's needed, and that allows you also to interpret the questionnaire results after when the patient returns with them the second time. We typically use full hour for an intake. That allows us to do a thorough examination, because sometimes also studying the medical record takes some time.
Okay, there are 3 elements there that really stood out that I want to address with you. The first one, as it came right at the end, is, okay, you get the hour. Do you ever have to translate that then into a third session or a second session of an extra half hour to go over that? And if you ever have to prolong your intake sessions with the patient, do you ever get any pushback from the patient as to, hey, why don't you have an answer yet? Tell me what's going on with my body. Because I know, just thinking back to some patients that I've dealt with, I definitely, if I sent them out the door with nothing, it would have either been a problem or that would have been the first and last time I see them. That's one element. And then the other two aspects, or the two elements, were part of the same coin, really. How important is it, even in a non-specific patient, for that clinical examination to be done if there are any physical findings that you find, to address those, so biomechanical properties? Do you put much work into that, or do you stay more lent onto the psychosocial aspects with more cognitive therapy? How do you take that approach forward? I suppose that the simplest and perhaps quickest one might be that first question of, do you get any pushback?
I think that's also an important one to address, because it relates to two things: expectations and also the therapeutic alliance that you hopefully develop well with your patient. Expectations relate to the image and the beliefs that the patient have of our profession. And of course, physiotherapy, there's therapy in there. So like you said, some of them at least expect to get treatment straight away, because they are often referred by a physician. The physician has done the diagnosis, so first physiotherapy session is treatment straight away. What we do to prevent that, and as soon as we started with doing that years ago, we never had any pushback on that one, in terms of they get a standard email that explains that the first session will be a full hour, and that it will be fully devoted to the intake, and that there will be no treatment in the first session, and that at the end of that session, hopefully we will discuss with them what the treatment options are, and that we will discuss it with them. That's the first important one, I think, and that's something everyone can implement if they are willing to do so. Second part of that question relates to, is 1 hour enough? In the setting where I work, and of course in a university hospital, we get like secondary referrals. I mean, it's secondary care, sometimes even tertiary care, but in general secondary care. And even in those patients, in my experience, it's nearly always enough. Of course, but in a minority of cases, I would say like 1 out of 20 patients, 1 hour is not enough. If that is the last patient of the day, that's no problem. Then you can extend a bit your session, and I'll get the cold dinner afterwards. But of course, if the patient is agreeing that we would also do the next session, or at least devote the next session partly to the continuation of the intake, then it's not a problem. Then you don't get a pushback. So in that case, if you see that the end of your hour is approaching, I typically discuss it openly with the patient, and I say, yeah, the next patient is already waiting in the waiting room. We had a full hour. We're not up to discussing the treatment options yet, so I still have to go through the medical record or whatever. Or the patient didn't fill out the questionnaires that we asked them to do. That's also a good one, because that's of course their responsibility. Then I discuss it with the patient, and I provide the options to them. Or we can now finish this up, but I don't have a clear picture of you yet, so anything I can say right now will be somehow premature and not final, or we can continue it the next time. So if you somehow leave the choice with the patient, then you don't get a pushback. And this is, of course, again, shared decision making. So that respect. And then you had another question, and I forgot that one. Sorry.
So the other question goes back to, like you said, you do the full physical clinical examination.
The biomechanics stuff. Yeah. That depends on from patient to patient, obviously. And yes, for sure, we do biomechanical motor control assessments, all those aspects. But again, the difficult thing, of course, is to do and that's the fun part also of the intake, to do the clinical reasoning. You bring everything together, and then you explore what is clinically relevant. And of course, the clinical relevance, for instance, of motor control in motor control problems in general to chronic pain is not that high as far as we know right now. Contrary to what we thought like 15 years ago, we now understand that this is probably a secondary phenomenon because all patients with chronic pain have motor control deficits. And we also understand now that this is a secondary phenomenon in terms of the pain is so threatening, so damaging, at least as considered and interpreted by the brain, that the brain uses and applies different motor control strategies to still do the body movement. So this is kind of the changes in motor control strategy applied by the brain to do the body movement is actually an escape route for the brain to allow the body movement to be performed, but somehow escaping from the threatening situation of doing that body movement in the way that the body was doing it before. So the majority of the changes in motor control that we see in neck pain patients, shoulder pain patients, knee pain patients, low back pain patients are adaptation strategies of the body to still allow doing the body movement, but somehow to escape from the pain, if you can call it that way. So they are secondary phenomena. Does that imply that they are not important? Not at all. I'm not saying that at all. But I'm saying that it should not be the first treatment target. The first treatment target should be to decrease the threat value of the pain. And this can be done by pain neuroscience education, graded activity, graded exposure therapy. Those kind of treatments are really effective to decrease the threat value of the pain. As soon as you're able to do that and the patient has settled down a bit, then reassess motor control and then have a look how the brain activates the muscles to perform those body movements. And then you often see that the motor control has improved already. And if it hasn't improved substantially enough and you still consider that the motor control deficits at that point in time require further treatment, then sure, integrate those motor control strategies in your treatment approach, in your exercise therapy for the patients. But don't use it as a first stage treatment, because that's not what they need, at least not the majority of the cases.
Okay, nice. And then something you mentioned there and mentioned also towards the beginning was patient beliefs, addressing those. Patients can catastrophize the situation, they can become oversensitive. How are you then working towards addressing that, as if that's going to be your primary approach, the primary target? What are your first steps with someone?
Well, first step is in those patients it's explaining pain, and explaining pain is then targeted at reconceptualizing pain, decreasing the threat value in general of any pain experience, but specifically the pain experiences that patients are affected by in daily life. So make sure that is always an individually tailored approach as well, and not a standard story that you tell them. And from there, it's very important to apply that to the daily life of the patients, and to do that, the approaches that I mentioned, like behavioral graded activity and graded exposure, are really nice ways of applying this to the life of the patients. Because many patients, you see, they fully engage in the pain neuroscience education, but then in the next phase still struggle to apply it in daily life, because they understand everything, they can even explain it themselves, but it still remains a bit artificial until they start to apply it in their own daily life. Then it becomes the real thing. And there you can really apply this new understanding to their own life, and how do they react to a pain flare when they start to do walking or cycling exercises, if they like that type of exercises or physical activity. Again, how do they react to that? And that's why the graded activity and the graded exposure approach is so nice to connect it with explaining pain. So those interventions to me are key to decreasing catastrophic thinking and improving cognitions in general and beliefs in general, and allowing patients to regain control over their life. I often use the words in clinical practice like during the intake, even, and to conclude the intake, I can use it in 9 out of 10 patients that come into us. Well, if I can summarize your situation, I think that pain is currently in control of your life. Pain is the director, the David Lynch of your life. And I think what you ask me to do is that you want to be in charge of your life again. And that's something we can actually offer by providing a multimodal approach. And then 9 out of 10 patients tell me that's exactly what it is. And then, of course, this also creates a bond with the patient because they feel understood. And this creates the therapeutic alliance. And we know that above all ingredients of any treatment approach for any chronic illness, therapeutic alliance is a key ingredient, and that's a major determinant of a positive outcome in the treatment approach.
How do you avoid flooding your patient with scientific information? How do you approach that aspect of providing them with just enough knowledge that they can get an idea of what's going on? And like you said, there's two elements to that as well. There's their understanding of it, and then there's their applying that as well. How do you avoid just throwing science at them and overflowing their minds and then getting them to the point where their eyes just glass over? Yeah.
Two things in that respect, or three things if I can relate to that. First, there's quite some evidence out there showing that clinicians in general underestimate the demand of the patient for scientific information. In fact, patients love it and they want more of it. But I agree that we shouldn't overload them with too much information. One strategy for us to do that is to cut back on the number of treatment sessions per week or even per month. Our multimodal approach is designed in a way that in the beginning we see the patients only once per week, because we give them always a lot of homework in the first phase, a lot of stuff to read or to look into on the internet. So, and that needs time to process. And this is a strategy to prevent overloading them with information and strategies that they can apply in their own daily life. Because any behavioral change, but also a change in mindset and a change in beliefs takes time. So that's one strategy that any clinician can apply in the clinic also. Cut back on the number of treatment sessions. I would never do 2 treatment sessions per week with one patient not in the early phase of treatment. So that's one thing. And even if you have a strategy of doing 2 sessions per week in the first phase, that's still fine, but then make sure that there are 2 short sessions. So I would not do 2 1-hour sessions per week. So that's one thing. Another thing is always do shared decision making. Don't just impose upon them. Don't hand over an information leaflet and tell them to read it at home. No, always tell them you are in charge. Is it okay if you read this information leaflet, or do you prefer to watch something on the internet? Or are you not open to doing any homework in between this and the next session? So leave it up to the patient to decide. And I always emphasize that sometimes even in every single session that I see the patient, that the patient is in control. I'm here to help you, to coach you, to assist you, but I'm not here to telling you what to do. It's you making the decision. So I always leave it up to the patient, including if we want to overload them with information.
Okay. So then you've got your patient in clinic. You've done your intake with them. You've explained pain to them. What's your next stage? Are you then starting to address beliefs? Are you then starting to address other factors? How do we carry this forward in practice?
As soon as they have improved their beliefs, due to the educational phase and they are ready for the next step, then again, it depends on the patients. In many patients, we then have different other aspects to address, such as physical activity, exercise therapy as one ingredient. Another ingredient in many patients is stress. In some patients, there's also the nutrition aspect or the sleep issue or whatever. But then again, it's shared decision making. They make the decision what's next. And I give them the options. And if, for instance, if sleep is an issue, then I also inform them about best evidence approach. And I tell them, well, when you would ask me, according to the evidence that we have, the scientific evidence, the best choice would be to first addressing sleep now, because we know that poor sleep is a barrier for effective exercise therapy, for instance. And of course, they need, and to explain this also to patients, you can easily explain this by saying, well, if you want to upgrade your exercise and physical activity levels, you need energy to do so, and you need to recover from those exercises. And what's recovery? It's having a good night of sleep. You currently don't have it, so I would advise you to first address the sleep issue. But if you're not up to it, or you feel uncomfortable with me as a physio addressing the sleep problems, we can explore on options to have this part of the treatment with a clinical psychologist. Or if you prefer to first address the stress issue, or first already start the exercise program, that's also fine with me, because of course many patients come in to the clinic, to a physio, with the beliefs or the expectations that they would get exercise therapy. So
I'd argue that.
Yeah. So
I'd argue something is massage.
If you postpone the exercise part too far, some patients start to feel uncomfortable. So there again, that should be their decision, and if you do it that way, you don't end up with unsatisfied patients.
Okay, and then what about lifestyle factors such as work? Because that can be a major trigger for some people.
Yeah,
I've had a patient before who we had to essentially get his working schedule down from a full day to 2 hours, and then slowly build back up from there. And he hated it in one aspect of he couldn't go to work. He enjoyed his job, but it was the major trigger. Within a few weeks, he was slowly building back up to half a day. He was happier with himself. He was happier at work. His boss was surprised at how quickly it had improved, where in the initial instance, the boss wanted him to just continue and drive on through or keep going with work. How are you going to approach that? Because that can have external complications that we as physios can't factor in for the patient.
Yeah, it's a very important issue also, and also a very difficult issue. In general, what we know is that it's a very bad idea to get patients off work. So don't advise them to quit temporarily their job, even though they have a social security system that prevents them to have a financial disadvantage from that. And even if the physician referring the patient proposes this, that's always a bad idea. The situation that the example that you gave is a nice example of a flexible employer who is willing to cut back temporarily, but not get the patient off work. So that's a nice example of how you can do it. In the majority of the patients that are also willing to continue their job, stress is a big issue, and stress at work in that respect is a big issue, and therefore the stress management ingredient of the multimodal approach is very key to address that one. And then, of course, this will include addressing the stressors at work. And from there, again, it's the patient's decision to whether or not it will be addressed together with the employer, and how it will be addressed. And that's also how the stress management program is designed, that you provide more insight to the patient in the role of stress, and also let the patient identify themselves their stressors in daily life, including their stressors at work, and also then provide options for them how they can address and improve the stress issue at work. So to me, that's a key issue. And of course, also the sleep issue is important in that respect, in terms of if they haven't slept well, of course, they're more vulnerable to stressful situations at work. So to me, those two aspects are really, really key. And of course, again, it depends on patients to patients, but yeah, it's difficult.
Okay. I'd be remiss if I didn't ask, as you mentioned it a couple of times, could you maybe give us an overview and the key pillars behind the multimodal approach?
Education, stress management, sleep management, exercise therapy, physical activity, nutritional intervention. Those are probably the most commonly applied modules in the multimodal approach. Of course, depending from patient to patient, some patients require specific traumatic treatment for addressing the trauma, and that's of course beyond the scope of physiotherapy practice, and therefore they need a psychiatric treatment or treatment with a clinical psychologist. For traumatic treatment, exposure treatment is also the number one evidence-based treatment. Also, besides traumas or trauma treatment, other psychiatric comorbidities need to be addressed, and that's also a pitfall for us physiotherapists. If there is a psychiatric comorbidity, for instance, an active depression, a clinically active depression, that needs to be addressed, at least together with the physiotherapy treatment, if not before starting the physiotherapy treatment. If it's not addressed by a psychiatrist or a clinical psychologist, then whatever we do with our patients will not be effective, because the psychiatric comorbidity is so dominating to the clinical picture of the patient. And of course, if patients are still smoking and a smoking cessation module can be part of the multimodal approach. Again, this can be beyond our scope of our profession, similar to a dietary intervention. That depends from country to country. We know that more and more physios are digging into that, but it depends also on the social system and the healthcare system, whether it's even allowed to include it in a physiotherapy approach. But yeah, that those in general are the most often included modules in an individually tailored multimodal approach.
Okay. You mentioned there the psychological comorbidities. What are the ones that we need to be aware of as red flags, or what things should we look out for as red flags to say that this is something we need to refer you out for straight away, just so that the therapy can be effective in future? And what are other red flags that we should look out for when dealing with a patient with central sensitization?
Well, in terms of psychiatric comorbidity, I mentioned a couple of, in terms of depression, in terms of past traumas or recent trauma, post-traumatic stress disorders. Those kind of things are really commonly related to chronic pain and central sensitization, and require evidence-based, specialized treatments that goes beyond the scope of our profession, obviously. Red flags, of course. For instance, if patients express suicide ideas, are obviously are red flags that you can consider there. Luckily, in this category, of course, they typically have seen often a number of physicians that have looked into it and referred them hopefully to psychiatrists or clinical psychologists to address this. If this is not the case, like I said, it's our job to explain this to the patient, and also to discuss it with the referring physician. In terms of other red flags in relation to central sensitization, I don't really think there are specific red flags then in relation to central sensitization. What, of course, is important to mention in relation to chronic pain in general, that you always need to be aware of the possibility of red flags, and that and that, of course, that's also one of the reasons why you do the clinical examination. And in that respect, it has been I've experienced this a number of times when I did the intake with patients, that I referred them to a neurologist, because I was suspecting a central nervous disorder rather than a pure chronic pain central sensitization problem. Having said that, of course, referring back to the explanation that we did in the early beginning, you can consider central sensitization also as a central nervous disorder. But of course, in this respect, I'm referring to the more established central nervous system disorders. So therefore, I think that's also very important to perform a clinical examination to exclude those possibilities. Including also and also the classical red flags for possible cancer is also very important, because we also know, and this is not per se something you want to share with your patients because this can further catastrophize them, but patients with chronic pain have an increased odds of developing cancer and cardiovascular diseases. And this is probably not a direct result from pain in itself, but is related to the unhealthy lifestyle associated with chronic pain. So therefore, we also need to be aware of possible red flags for cardiovascular diseases and cancer, specifically in the chronic pain population.
Okay. Moving back more towards the physiotherapy side of it, in the traditional sense of exercise therapy, you mentioned a graded exposure program. What are the metrics that you're using at each stage of your therapy, from going from talking about their catastrophizing beliefs and working on those, to then going into exercise therapy and then to start increasing their therapy? How are you then moderating that? How are you measuring that? What are the elements that you take forward there?
Well, rather simple, I would say, when you just look at how I do it in the clinic, because one key element there is asking them what kind of activities or body movements or movements in general what kind of activities and exercises are you avoiding right now? But I don't use the word avoiding. I use what kind of activities are you no longer doing because of your pain? And that also sometimes relates to activities that they have deleted from their life, sometimes months or years ago, and that they didn't bring up when I questioned their expectations for care, because they already accepted the fact that they would never be able to return back to playing tennis, for instance, because several physicians already told them that that was out of scope for them for the rest of their life. So those are the high fear activities, but I don't use words like avoiding or fear in the clinic. I ask them, how threatening would it be if you would consider walking back on a tennis court and start playing tennis? How threatening would that be on a scale from 0 to 10? And I don't let them fill out a piece of paper for that. I just ask this, with 0 not being threatening at all, 10 being extremely threatening to you. And typically then, in those situations where it relates to activities that they have been avoiding for years and haven't been doing for years, obviously, you get rather high scores, like 7, 8, or even higher on a scale from 0 to 10. And that's kind of the metrics that I use then. And then I will ask the same question after we have started integrating those activities in a graded exposure approach, because that's an important message also for clinicians. Those kind of high fear activities, they will not be improved or integrated again in the life of the patients if you apply a graded activity approach. Graded activity is very useful for medium and low feared activities, but not for the very high feared activities. For those activities, you need a graded exposure approach. And of course, you can only address those activities, those high fear activities, if the patient is happy to get back to them. Yeah. If they say, no, leave it as it is, I'm fine with never being able to return to the court, that's also fine. But even if they say it in the first session, ask the same question again after they did the explained pain phase. Because if the threat value of pain has decreased and if they understand their condition much better, then this also somehow changes their viewpoint in terms of what kind of things can I aim for in my life again. But still, if they are not happy to return to it, leave it as it is. But if they are saying, okay, yeah, that would be nice, and you sometimes see the eyes of the patients then starting to become really different, and their face turns into, oh, that would be fantastic if I would be able to do that. But still, it's a high fear activity. So then we and it's a too big step also after the explained pain phase to start even doing the body movements. For instance, low back pain patients often have a high fear towards doing the tennis serve, because that obviously puts a lot of stress on the lower back region. And then even doing such a body movement without even a tennis racket in your practice, in your exercise room is too high. Then you just do a motor imagery. You ask them to do motor imagery together with you, and then do homework exercises, motor imagery, and that's always already enough in many of those patients to trigger a pain flare. Can you imagine that they just lie down on a couch like this and they close their eyes and they imagine that they walk back on a tennis court and start to practice their tennis serve. That increases their heart rate. It triggers a small stress response and sometimes even triggers a short-term low back pain increase. So that says it all, how dominant the brain is in terms of creating pain as an output product of the brain. So, and that's really useful then for them also for understanding their own pain problem and for being convinced that they should be able to retrain their brain again, and that the problem is not in their back, which is of course a major relief to them and allows them to get confidence once again in their lower back region to get them back to play tennis.
Okay, interesting. I like that approach to it. And what are your steps for then building off with a patient, ramping down treatment, getting them ready to take on the world on their own without any intervention from the physiotherapist, being able to deal with their flare-ups, being able to deal with whatever issues life is going to throw at them? Because let's not kid ourselves, they're going to have a flare-up at some point further down the line. If it's 6 months, a year, or 2 years down the line, hopefully the later the better. We want our patients to have long-term results, not just 2 weeks. How are you then building off?
Well, because the approach is so directed at their daily life, we see also in the trials that we did that even to me, 3 months of treatment is rather short term, but the trial that we published a couple of years ago showed that 1 year after treatment cessation, the results were still nearly the same as when they left the treatments. So this also shows that we are preparing them well for an independent life. But the strategy that we apply in the clinic is also in line with what I've previously explained in terms of cutting back on the number of treatment sessions per week, allows you also to to follow up the patient longer. And so in the beginning, we have like 1 treatment session per week that then decreases to 1 treatment session per 2 weeks, and in a later stage, even 1 session per month. And this typically allows us to have a 5-6 month treatment program and to follow up the patient. If you have a 5-6 month period where you follow up that patient, then of course they always had at least 1 flare-up in that period, and that's very useful because it allows them to discuss and express their concerns about it together with you while they're still in the program, and this allows you to put them back on the rails. And of course, in that stage, for instance, when they are already receiving 3 months of treatment with you and they experience a flare-up and they return to you, then the pitfall would be to just manage it for the patient. But no, at that point in time, of course, the patient is well educated, has obtained the skills to self-manage their problems. So it's just asking a couple of questions, making them reflect on how they are currently coping with their pain problem to get them back on the rails. That's often the case. And as soon as you were able to, if you were able to do that once, then you well prepare them for subsequent flare-ups. And of course, the graded activity approach is very well addressing that issue, because you independently of the pain and pain flares, you build up and you gradually grade your physical activity level, which is perfect to address that also.
Okay, great.
A final thing, if I can add one small thing to that, is that we often try to also keep 1 session left before finishing up the treatment. This way, okay, we say to the patient, okay, you had a prescription of 20 sessions, for instance, but we still have 1 session left. So we keep that one. Feel free to contact me anytime if you need that reactivation session, or if you're experiencing some difficulties, you need a reminder session. We often call it is needed.
Sounds like a good system there. If they're getting prescribed that many sessions for that,
True.
Yeah. Definitely don't have that here in the Netherlands. But one of the reasons that you're here with us in the studio today is that you've also been working on a course with ourselves here at Physiotutors. Can you maybe briefly talk to us about that? What is it that went into the course, and what is it that people are going to be discovering and learning on the course as well?
In the course participants are learning about our current understanding of central sensitization. We briefly address this in this conversation. Of course, we go much more into the details about the neurophysiology, the neuroscience behind central sensitization in people with chronic pain. Of course, that's the first part, the more theoretical part. In general, the course is targeted at providing clinicians skills how to recognize central sensitization in clinical practice, including a variety of using a variety of learning methods, such as online lectures, reading material, multiple choice questions, case studies. So we're investing in that course a lot on skills, also clinical reasoning skills. So not only at recognizing central sensitization in clinical practice, but also on pain neuroscience education. So we teach them the basic skills for explaining pain to their patients, and all the other aspects that I mentioned in terms of the different ingredients of the multimodal approach are addressed in terms of providing that's what clinicians can take from it. They get the basic skills to provide sleep management, stress management, etc. Also, the exercise therapy, graded activity, and graded exposure approach are addressed, allowing clinicians to apply this in their own clinical situation.
Cool. And it's also a fair few hours of content as well. It's worth more than a weekend.
Yeah.
Great. And have you got any personal learning moments where perhaps things didn't go to plan with patients that you could share with us? Something that we, as the listeners and myself, can take away, the nuggets of wisdom that you have in your many moons, many trips around the sun.
Yeah, sure. And the thing that I often say to clinicians is that, to me, it's much more easier to talk about this and to teach about this than to actually do it in clinical practice, even though I love to do it in clinical practice, but I still often struggle with it myself. Of course, not in the majority of the cases, but there are patients that I found difficult to treat myself. I think we addressed one group of patients where it's really difficult, the socially vulnerable group, especially the ones who are having a different cultural background than the classical Western society has. That's for sure a vulnerable group for me as a clinician to address, and also when there is a language barrier, that's also very difficult if their native language is not Dutch, and if their second language is not English, or if their English is not good enough as a second language, then I really struggle to engage them well in the program and to build a therapeutic alliance. That's partly due to my poor French language skills, even though it's such a beautiful language, and I'm a bit embarrassed to say this as a Belgian guy, but still, that's for sure a group of patients where it's difficult to get our hands on. Yeah.
Okay. And have you got any other little further reading recommendations or anything for people if they wanted to skill up even slightly?
Well, that's a tricky one because there's so many nice research out there to learn from, and you mentioned learning moments. Well, every single congress or lecture that I attend from colleagues, I always learn, and I learn from discussing it with fellow clinicians, and that's also probably an important one for the people at home watching it. Discuss patients and clinical situations and problems that you're faced with in the clinic with your colleagues because that's where you learn from it. For instance, I recall recently that we had a follow-up training moment for clinicians who are acting or are providing treatment in ongoing clinical trials, and just from the questions that I had from those clinicians, the problems that they were faced with, I learned a lot from, by discussing it together with them. So discussing problems that you're faced with in the clinic with colleagues, I think it's a major thing, because we can learn so much from each other, and it doesn't really matter whether you are experienced and as a clinician and discuss it with a junior clinician, if you can call it that way. You can always learn a lot also from those junior clinicians, also because they had a different training as you did back then, just because other people were teaching to them as the people who were teaching to you when you were in college.
Yeah, we're an amalgamation of those who have taught us, essentially. Yeah. Hopefully taking their best skills, and maybe not the bad habits that we may have picked up. What do you think it is about your approach that's different to somebody else?
I'm not quite sure that our approach is that different from somebody else's approaches. When you look at the chronic pain community worldwide in terms of scientists and clinicians all together, I think there is a common ground. There is a firm evidence now that a multimodal approach is best evidence, and the different components that we mentioned are all really evidence-based, perhaps except from the nutritional aspect that needs further development. So I don't think our approach is that different as compared to many other settings, especially not the settings where they actually apply best evidence care. Perhaps what we do a bit different as compared to many settings is that we don't work multi or interdisciplinary with all patients. And that's also something that clinicians can take away if they don't have the capacity to work in a multidisciplinary setting, they can do a lot of good for patients just in a monodisciplinary setting. In fact, the large majority of evidence for treating chronic pain comes from monodisciplinary treatment studies. And this is often, a bit misunderstood, that multidisciplinary treatment is the best you can give to patients. I don't disagree with that statement, but multidisciplinary is only best evidence, I would say, if it's done really in an interdisciplinary way. So if all therapists are really aligned with one another, and if they discuss every single patient that they are treating together, and that they are really treating them in a team, because if not, if it's pure multidisciplinary and every discipline works independent from one another, then you see that the results are often not that good. So keep that in mind. If you don't have the capacity or the resources to provide multidisciplinary care to your patients, that's not always a problem. Make sure that the treatment is multimodal, and then you can do a lot of good for your patients. And then, of course, for the really complex cases, and especially if there's psychiatric comorbidity, you need to work interdisciplinary, but it's not necessary for all patients with chronic pain, not at all.
Fair. This question probably requires more speculation from your part, but do you think that maybe one of the reasons that monodisciplinary can sometimes prove more beneficial than the multidisciplinary, if it is truly multidisciplinary where there's no communication or minimal communication, versus the interdisciplinary team, is because they come into one person and there's consistency both in that individual's program? Because of what you often see with people with chronic pain is these belief systems are so ingrained that if you're then going to go separate out to me, to Andy, to Kai, to you, and 4 or 5 different people, so much is lost. Whereas when they come to one person, even though we as physiotherapists aren't going to be as skilled as a psychologist, aren't going to be as skilled as someone who deals purely with sleep therapy, maybe we're not at level 100 in those aspects, because they have that consistency from one person. Do you think that that's the element there that can make the difference for somebody?
Absolutely, yeah. It's a yellow flag. Conflicting messages from different clinicians is a yellow flag. So that's probably the briefest answer I will give today. But yeah, you've explained this very, very thoroughly.
Nice. Thanks. 2 thumbs up. Great. Where can people find you? How can people find you, be it on social media or whatnot, if they want to follow what you're doing in terms of research, or if they want to see what you're posting, if you post on socials?
So we have our website, the Pain in Motion website, www.paininmotion.be, and that's connected to our social media. So Pain in Motion is also available on Twitter, Facebook, Instagram, LinkedIn. Me personally, I'm on ResearchGate. So yeah, that's about it.
Okay, fantastic. Yeah. Well, look, thank you very much. Really appreciate your time. Really appreciate you being able to sit here and have a chat with me about central sensitization. Thanks.
Thank you for having me.
Well, ladies and gents, thanks for listening. And if you can, we'd really appreciate it if you can leave a like and subscribe, or leave a review for us wherever you're listening to your podcasts, whether this is on YouTube or iTunes or where have you. Really appreciate it. And enjoy the rest of your day.